There's actually just abscess. I've never seen just an abscess. If they got something below cooking, they're going to have something on top cooking. You're going to see some redness, some warmth, some pain. So cellulitis is an acute, this is not a chronic condition, spreading, meaning I started out here at 5 millimeters, 48 hours later I'm at 5 centimeters. Acute spreading infection of the skin with visually, this is important, indistinct borders. And it's important here in a little bit when we get to erysipelas. Indistinct means it's like there's kind of some shading there. Because the condition we'll get to in a bit, it's like a stinking step-off border. Like you cannot believe how distinct it is. It's important to diagnose the two conditions. Bless you. So acute spreading infection of the skin with visually indistinct borders that involves the dermis and the sub-Q tissue. Don't get caught up in that. I would never ask you a test question that says, what layers does cellulitis? I wouldn't ask you that stuff. Yes, ma'am.
What's the fine line between like referring a cellulitis patient to derm or to wound care?
Okay, I would never send them, well, not so much derm, because there are probably tons of derm that actually will send infectious type stuff to somebody else. That's a great question. I would definitely go to wound care before I go to derm, because it can also take about 6 months to get into derm. You should feel fully competent to manage a cellulitis as a provider. Absolutely, this isn't all my slides, get wound care involved. They are amazing. I would refer them to wound care right then and there. Because wound care is just your extra set of eyes on your patient. They will go out on the weekends. They will go out after hours with your patient. So I saw Sally Sue in clinic. I started her on some Bactrim. She got a little hold there. She's diabetic. I got to keep a close eye on you because you want to take care of yourself. I will refer them to wound care and be like, I want you to go out to this lady's house every day for a week and give me a report on what it's looking like. That's a great question. Wound care, I go to wound care, not derm. Derm's not going to manage your, for the most part, they're not going to manage your acute infectious type processes. Because if you think about wound care, people can't afford or have the means to come see you. Like, I need to do a 48-hour follow-up. Oh, crap, it still looks bad. I need to see you again in 48 hours. Oh, crap. They will only pay Medicare, but they will only pay for so many visits. So that's why you get wound care. Because you're like, I can't bring you up to this clinic every day this week. I can't. So I'm going to have them come to you. And that wound care nurse will call you and say, here's how it looks. It's 3 centimeters by 2 centimeters. There's some, they will keep, it's amazing. I love me some wound care. That's a great question. And that's just a simple referral process. You just put it in for wound care. Don't get caught up in bullet point number 2. Just know, like everything we've already talked about, if the conditions are right and the person is immunocompromised, anything that's superficial can obviously, if it's not managed, get deeper and cause a lot of bad business. But these can. Cellulitis can turn bad quick. Again, cellulitis can be anywhere, but it typically is on leg, face, arm, buttocks. I think of it as a lot of times, for the buttocks, it's on the butt a lot. But it's because friction. Think about it. People sit on their butts all the time. They get a tiny little furnicle. They don't take care of it, and it just gets bigger and bigger and bigger and bigger, and then you have this huge cellulitis with it. Kids, for whatever weird reason, I wrote upper on there, they get them on their stinking thighs. Every kid I've ever drained's either been on their thighs or their butt cheek. Epidemiology, you read that, I would never test you over that. I am not going to test you over this slide, because it's a lot, but please be mindful that there are different terminology, wording types of legit coded cellulitis. And some of these you've already been given in your ENT course. Periorbital, orbital cellulitis, as you know that between that little septum, what's in front, what's considered in back. Facial, buccal, peritonsillar, perianal is another big one. If you ever have someone that comes in with an abscess or cellulitis around their anus, don't touch it. They have to go straight to surgery. If you went and looked up somewhere, there may be one of these that would stick out more to the other. I don't know. But it's one that has a very common, it's the two. It's not a just staph aureus. So beta hemolytic strep, it can be any one of those groups, A, B, C, G, or F. So for cellulitis, I probably wouldn't ask you that question because there are two different ones. I've given you the other bugs down below that's more common for some of the other types of cellulitis, where they're located anatomically. I will not write test questions on down that list. I just want you to be aware of that. Risk factors, much like what we've already talked about. Anybody immunocompromised, anything that messes with the skin barrier, bless you. Drug use is something we often overlook. You'll know it when you see, well, I say that, you don't always know it. But you do need to be mindful of that. If an individual's coming in with cellulitis, a gnarly wound, if you suspect that they are an IV drug user, you need to be mindful because they have a different type of bug that can commonly affect them. So you have to tailor your treatment to them. So if you know you have an IV drug user and they're coming in with a big nasty wound, think about that. Put those two together. There's a difference. IV drug users are also your ones that will develop nasty, bad abscesses, and they'll also get them in their, they get them really bad in their spinal column because of stuff being introduced to them from their needle. There are some people that have recurrent cellulitis. And I've given you some of the listing there of those individuals. Be mindful of this. I try to tell students this. Any medication you give a patient has potential side effect or bad. Think about it. So I'm always careful when I give people. Steroids can cause people to have issues with cellulitis and clearing it. Because what do we know steroids do? Which kind of sounds weird if you think about it, like, but they help us so much. What do steroids kind of do? One thing they do. Yeah, that's exactly right. That's why you don't ever stinking give those to somebody that you think has any type of bacterial infection in their body. That's why I laugh when people come and see me and they went to an urgent care and they said, yeah, I have pneumonia. They gave me a Z-Pack and albuterol Heller and that round of steroids. I'm like, well, if they really thought that, they're incompetent because you have a pneumonia that could do bad things. Diagnoses on these folks, patient history. This, again, these people, for the most part, every cellulitic person I got, they were somewhat of a complicated. I mean, anybody can get cellulitis. Don't get me wrong. Most of the people that I saw in family medicine were not your healthy 21-year-old, I run every day, don't smoke, drink. They just, you'll see them. They're like these certain types of patients. And I don't mean that in a derogatory manner, but they're either diabetic, they have a lot of comorbidities, they're overweight, they're on a lot of meds, they're lower socioeconomic status. It is a certain type of patient. So this is not just, oh, you got cellulitis, okay, here's some, you're going to need to delve into this a little bit more. So history is really important with these people. I put the first bullet point in there. God, you're going to get this all the time. And it's one of my hot button. It's kind of like, I got a staph infection, like you were saying. People blame everything on spiders. You probably, Travis, you're playing on this from your ER. You scribed, right? Did you scribe for ER dogs a lot?
No, just family practice.
Oh, well, did you get spider bites run rampant? I mean, they love people, they graze apparently on people. Every stinking person that comes is like, I have this spider bite. I'm like, have you ever seen a brown recluse bite? Has anybody ever seen a brown recluse spider bite? It will jack you up.
Yeah.
It's not just, that's just right here. No. Black widow's pretty rough. Brown recluse is rough. I mean, it will eat your skin away. And instead of laughing at them, you can laugh at them internally, because I do. Tell them, just say, honestly, this is probably not a spider bite. Educate them, tell them, bless you. Normally, if you get a good history, there's some trauma. I stepped on a nail, I was outside working in the yard, scraped my leg on some metal, or there may not be. And again, often have a history of cellulitis. Be sure and review their past medical history, their surgeries, their medications. Because again, these folks are not your healthy, everything's groovy. And you want to know what their past medical history is, because if they are diabetic, which I think everybody in Oklahoma is for the most part, you're going to have to take that into consideration when you have skin infections. The medication's important because of immune modulators, excuse me, if they're on any type of chronic steroids, you have to take that into consideration. And remember, inhaled steroids are just as, well, no, they're not just as potent as your systemic. But don't ever forget inhaled steroids. People always pass that off. Pill steroids are rough, yeah, but inhaled, like a, you know, a puffer, it can also cause issues, steroid-wise. So, these are your signs and symptoms. This is how they're going to clinically present to you. Things that we've already been talking about. I threw in the bullet point number 2, because you're like, wow, really, that's, we get it. But you would be, think about that. If you ever have somebody, because I told you this other day, you're going to have these patients that are going to come in, they have horrible arterial or venous insufficiency, they're diabetics, they're hypertensive, and they're from like right here down. They're going to be hot, red, swollen, and you're going to be like, oh my God, that's a horrible cellulitis. I'm going to give you antibiotics. If it is bilateral, the odds of it being an infectious prostate goes down astronomically. I'm not saying it can't be. Most cellulitic patients, it's going to be unilateral. It will help you if you think about it like that. The erythema can range mildly pink to bright red or bright erythemas. And you can actually type out mildly pink, mildly red. You could say that. That's okay. You can have some edema induration. They can have some systemic symptoms. Now, I have seen people with cellulitis have systemic symptoms. Absolutely. And it's usually, again, those comorbidity type people. Diabetics, overweight, unhealthy, they don't have a lot of reserve there. They can get that paid orange, however you say it, like in your breast lecture. If the skin becomes so swollen and edematous, the little pores will start to pucker in, and it looks like an orange peel. They can have lymphadenopathy, because again, you don't really can get the lymphadenopathy with your folliculitis and your vernicle. No, because it's not, this is a little bit more severe. So you can actually get some lymph nodes that are swollen, because the body is trying to kick it up a little bit. I told you about the red streaking. That is lymphangitis. That is essentially, that infection has went deeper. It's now, quote unquote, I guess, in their bloodstream. And it is now affecting lymph nodes, because lymph nodes basically pass off infection to each other. It's like the infection assembly line to filter, to help with your body. So each lymph node that passes off that blood, that infection, will be affected. And it will follow a certain lymph node pattern, and that's where you get like a main side of cellulitis, and you'll get what's called red streaking all the way from it, and that's not good, because those lymph nodes are involved. That's why after every cellulitic patient in my note, I'll say, no red streaking present. Meaning, I looked, and it wasn't there when I saw them, so if they come to you and they have it, they didn't have it when I saw them. Red streaking is serious. You need to probably put them inpatient. That red there, we'll get to this in a sec, they could have an accompanying abscess with it. There could be some lovely pus below forming. Doesn't have to be though. Borders are indistinct. That's not a great picture, but there's you some cellulitis. This is an example of cellulitis with red streaking. Do you see how that's moving up on her inner thigh? That's not good, which is why she has a hospital gown on. But I love how they drew those borders, and you can do that in your family medicine clinic. Even if you don't have a surgical marker, go get a big pen or a Sharpie or something. It's okay, you can totally do that. This is a really good foot cellulitis. Look at those toenails. You can have wound care come in and do people's toenails. Take care of their feet. Podiatry can take care of that. Wound care is where I would see this patient. Who wants to describe this? Gross. Just don't tell me. It is gross. Come on, somebody jump out there. Don't be afraid. Yes. Look at you. It's because you have confidence.
Erythema, mainly located on the midfoot.
Yes.
More on the medial aspect with center pustule. Do you want me to describe the toes too, or just mainly the red part?
You don't have to, but you could. Yeah, you would. You'd say toenails are, you want to?
Are decaying.
Much like my son. You would say, think about the phys-di lecture, thickened, discolored.
Thickened, discolored, lifted maybe?
Absolutely, not attached to nail bed.
Yeah.
Several patches of dry skin. Rough texture on the heel noted, some cracking visualized on the heel. No red streaking present, increased warmth of touch, patient reported pain with touch. Anytime also, if you want to get real good, if I have cellulitis that's anywhere, any kind of joint, near any kind of joint, I will move their joint. Like ankle, toes, no pain in joints with movement, because if it goes to that joint, you're in trouble. So just to cover my butt, but great job. Yeah, you did great. Good job. Thank you for jumping out there.
Can I ask a question really fast?
Of course you
So
can.
on the slide with the clinical presentation where it says accompanying SQ abscess, how long are you thinking to treat them before you start thinking, like, what's considered treatment failure? Because if it can turn serious, how long are you wanting to mess around with it before you think there's something else going on?
That's a great question. I'll get to it in a minute, my treatment slide.
Okay.
I have a question.
Don't be sorry, it's just like, yes.
Could you describe that, like, I know we're not supposed to put a diagnosis in our note, but could you say open abscess with, like, and then a measurement with accompanying cellulitis with this measurement?
I wouldn't use the word abscess or cellulitis. No one's gonna get onto you for it. But I would just say open wound, open lesion, you try to use your descriptions in your physical exam. You try to steer clear of that type of stuff. It's not wrong though, no one will get onto you for it.
How would you describe the discharge?
I would say, you could say purulent, you could say serous like a yellowy, it looks more yellowy and clear to me.
Yeah.
You could just say exudate, discharge. I just try to be descriptive with you. I try to set the bar up here for you. You can go in between that. I'm just serious. Like, you don't know, you're going to read notes and laugh and be like, why did she tell me to do all this? That doesn't mean what they're doing is right. It just means you're going to be better than them. People are gonna pick up your notes and go, this is what I'm shooting for. I'd say serious drainage. This would be kind of going into your, from this out of the day, that's like a paradicia there. And you could just comment, lateral medial folds, erythematous fluctuant mass present, nail intact, patient reports pain with movement of second digit, erythematous line drawn. You could describe that in many different ways.
Could you lamp that on
I would put a needle in that. Yeah, sure. Here's the kicker, and this kind of goes along with your slide, but I'll get to your question specifically. Anytime you see a bubble, a white pus, put something in it. Either an 18 gauge or a blade. And because if you know about abscesses or pus being walled off, it essentially, anytime fluid starts to collect in the human body, all those protective things start going to it and start trying to fight it off. Those macrophages, they all start punching at it, trying to get rid of it. It will form a protective wall around it. That's your body's way of trying to protect the rest of the body from that infection. But that wall actually protects it against antibiotics. So that's why if you ever have fluid or an abscess, discharge, pus, whatever you want to call it, you need to get it out of there in order for it to work. Yeah, I would. I was going to do it today, but there's no way, there's enough time because I know I'm a talker. I've asked Nikki to give me an hour somewhere. I'm going to show you a abscess drainage, how you would do one, and I'll do it under this, like a real one with a chicken breast. Last year in my derm course, everybody did one. Everybody drained one themselves, but Nikki's doing something different with you guys. She's doing a punch biopsy. But I'll do one for you here, and I have a little packet I gave last year of like, when do you do an abscess, what are all the tools you need to do it, get them ready for you, go in the damn room, what a consent form looks like, the whole 9 yards, and you can have it with you when you go out on your rotations. So I'll do that, and y'all can record it or whatever you want to do that day. It's kind of cool. Different types of cellulitis, please read these. It's coupled with that one slide that told you the different locations of cellulitis. These are just the symptoms that accompany that. Facial cellulitis, orbital. So how do we work it up? Again, if you feel really comfortable, your patient's stable, you have a great relationship with them, you don't have to do anything. 9 times out of 10, I did not order any labs on my patients with cellulitis or abscess. I just didn't. It's a waste. If there's limited area involvement, there's no real pain, if there's not any systemic signs, if they don't have any real risk factors, don't work them up. It's a waste of resources, time, and money. If you think your patient is quote-unquote toxic or systemically ill, this is what the IDSA recommends that you work them up with, if you really want to go that route. And there's nothing wrong with that. If they fit that clinical picture of systemic toxicity or starting to go in that direction, you can definitely do a workup. Here's the workup you need to do. Don't just order a CBC on them. You're going to need to do other things. Because sepsis is not just white blood cells. It's a lot of other things that start to become released in the body. Lactic acid being a big one. People often do not order that. And I'm like, you just totally wasted your time and theirs. So I wrote out for you what you need to order. If you want to do it, if you want to do a good septic workup, besides an LP, LP's not in here. This is your, if you were into an ER and you were going to do a septic workup, here she blew. Other than urine, chest x-ray, and an LP. Blood cultures usually ×2. CBC with diff, you want your diff. Why do you want a diff? That's exactly right. Because different white blood cells mean different things. And it will break it down for you. What's the white blood cell that you would see? Hopefully, maybe, if it was really a true bacterial infection. Exactly, yeah, you see? Okay. And this even gives you some guidelines of when blood cultures are important. Animal bites are one that I can tell you a lot of people will go, they'll do a shotgun approach with that. They'll go the extra mile. Animal bites can turn nasty very, very quickly. Other than this little no-kill zone here that you want to mess with, hands are another one I'd be very careful with as a PA. Don't mess with hands too terribly much. There are hand specialists that rotate through all the major hospitals in Oklahoma. There are not very many. So if anybody ever comes in with a bad bite or anything, you get them to a hand specialist because it can turn bad quick and they won't have their hands. So hands, another thing I will not mess with. If you did want to order some imaging, now I've done this before. You can. Here are the different types, the indications, and what you would potentially see on them. Now, I would expect you to go out and pick up a book and read a little bit more on these types of imagings and what you would see, but this is just kind of the general idea. The times I've actually ordered stuff on folks, I always start with the plain film. I order it if they have cellulitis secondary to any kind of trauma. I stepped on a nail. I had a guy shot himself with a nail gun. I mean, like, you want to see, is there something foreign in your body from that foreign object? Did it hit a bone? That would be a time to do a plain film. Also, if you ever suspect osteomyelitis, and you will get this more than you want, especially your diabetics. They'll come in with bad cellulitis, probably an open wound. You're going to want to get some imaging to make sure it has not affected their bone yet. So there are times you can do some imaging and it would not be inappropriate. Again, once you get out and you practice and you feel competent with it, you'll know when that time is. Doesn't have to be on everybody. A really cool thing you can do if you have an ultrasound machine in your clinic, which I would highly suggest you learn how to use it. You can do all sorts of cool stuff with ultrasound machines. If you ever have someone who has a really bad cellulitis and you can kind of feel some induration and you're like, God, do I put a blade in them? Do I not? Do I? You can go get a bedside ultrasound and put it on there and see if there's like a big old abscess brewing underneath. And you can leave it on there and you can take your blade and you can watch on the screen as it go in to see if you hit it. So a bedside ultrasound is awesome to use in that instance. It can help guide your blade. Just a little something. You can also use it if you, and I never got good enough to do this, you can also utilize it if you have a cellulitis next to a joint and you want to make sure that joint is not got something starting in it. You can put it on that joint and make sure there's not any extra fluid spaces because there's all sorts of cool calculation ultrasound machines will give you for joints and stuff, like this space should only be this big, this should only do this, and it will pull it up on the screen. So once you stick it on there, it'll say it's over whatever it is, and you'll go, ow, that's not good. There's some inflammation, there's some fluid collecting there. We need to do something more with this. Anybody here ever had experience with ultrasounds, using them, doing stuff with them? They're pretty cool, but hard. They are hard to learn. Treatment, okay Tyler, this is going along with yours. Before we get to specifically your question, general measures. So if they come into you and you're like on that fence, like you're healthy, young, you never had this before, I'm not going to throw antibiotics at you today. You're going to do some more compresses, take some ibuprofen, do some elevation for me. You're going to come back and see me in 48, 72 hours. If it's worse, or you have any worsening of symptoms between now and then, you come back and see me before that. And that's where you can, we need to do some antibiotics. If I put them on antibiotics, I still follow up with them in 48 hours because you can have treatment failure. And that's what that slide was saying. They can leave your office with just a good old cellulitis. You put them on some Bactrim, you bring them back in 48 hours, 72 hours. Now they have an abscess. You had treatment failure technically there. Always follow up with your cellulitis. Always follow up with your abscesses. Taylor, I probably didn't answer you. Does that help at all?
Yeah, I'm just thinking like timeline wise, so if you have someone come into your ER, you think they have cellulitis, and then they come back again, and it's still not better, so you change your antibiotics, at what point do you say, you know, like, we need to do something different, like we should admit you, or,
I don't have a straight answer for you on that. I mean, I would say 2 times if they've come back to you and you're still not getting good results with 2 different antibiotic switches. Or if they came back to you after those 2 and their symptoms were taking a major tank, like now they got a fever. They didn't have a fever 4 days ago. Or now they're nauseous. Or now their blood sugars are out of whack control because of this infection if they're diabetic. At that point, if it's ER or even family medicine, you need to put them inpatient. I don't have an exact how many times. How many times do you have to fail before I need to put you inpatient and have ID come and see you? I would give it 2 times, but I'd look at their symptoms outside of that. Are you starting to develop systemic symptoms? Because that's not good. And are you diabetic? I got to take you a little bit more seriously. You're going inpatient. Because at that time they'll do IV antibiotics, they'll do an ultrasound to make sure there's not a big, because you can be fooled. There can be an abscess down there deep brewing and you don't even know it. They'll take them in, they'll do an ultrasound guided in the OR to see if they need to drain it. They'll do infectious disease will come by. You'll do IV antibiotics. Does that help at all? These again are just general measures. And that's basically what the last bullet point is. Good patient education and follow-up. Good follow-up. Come back and see me. If it doesn't get better, go straight to the ER. You've got to do that in your note. Treatment plan. Target treatments in the setting of known pathogens. Again, it depends on what happened to the person. Animal bites are kind of funky. They have certain, wait, no, is that the human? Pasteurella is cat. Ichanella, I believe, is human bite. I should know that. It's either dog or human. Because you always think about this, you always think about animal. They're called fight bites. People get fist bites, and now someone's tooth will knock into them, and they will get a horrible infection. I think it's Ichanella from human mouth. Look that up, please. I'm sorry. If it's mild, and they are not fitting that clinical picture of your overweight diabetic on 22 medications, horrible follow-up patient, you can treat them with some mild, easygoing antibiotics. And these are them. Nothing different here that we've already introduced you to. Is it Ichanella? That's why you have to be really careful. I don't ever do it. Well, I did, and then they don't sometimes. You know, if you ever have a cat bite, dog bite, human bite, you usually don't suture them up. Because if it gets all puffy and bleh, it's not good. You let them drain. If it's a diabetic, they're different. It's going to be a different medication. It's usually this and this. Because you've got to cover for more than just your run-of-the-mill. It's anaerobes and aerobics. Metronidazole is really good. I use metronidazole a lot with my diabetic foot ulcer patients. Here's some inpatient considerations, Taylor. This will help out a little bit maybe with your question. Unreliable patients are huge. Don't ever feel like you can't. Now, there's always reasons to get people admitted. Like, you can't just admit everybody. It's called inpatient criteria. They have to meet it before they can get in the hospital. But if you ever have a patient that you know is just flaky, and you can put them in to give them IV antibiotics if you know they're not going to stick with it. Patient monitoring. This is kind of inpatient stuff. If you were following them up and they were not getting better and they look toxic, you can obviously repeat the labs to see if it's trending down. If they're inpatient, you always want to consider DVT prophylaxis. The last bullet point's really important. Don't ever bring somebody back too soon. It's the worst thing in the world, because they'll come back and you'll be like, oh my God, this is horrible. Don't ever do 24 hours. 72 hours is like my go-to, unless it's going on to the weekend. But if you do 24, maybe even 48, you run the risk of it looking horrible and being like, oh my God. No, it's just it takes some time for that antibiotic to get in their system. And you tell the patient that too, because they'll call you 24 hours mad. Yes, you've only taken 1 day of antibiotics. We need 3 full days here. So 72 hours is a really good follow-up guideline. Differential diagnoses, you can look at these. DVT is huge. I've done it a million times. I'll be like, is this a cellulitis? Is this a DVT? What is this? What is this? Again, that goes back to your unilateral versus bilateral. Most DVTs are unilateral though, most cellulitis are unilateral. So there will be instances where you'll be like, I freaking don't know. Again, it's digging into the history. One, have you ever had cellulitis, or have you ever had a blood clot? And then just doing a really good physical exam on them. But if you're ever on the fence, do not be afraid to go send them for an ultrasound. Who cares? It'll come back normal and you'll feel good. You'll go to bed at night knowing that it wasn't a DVT. You could get a D dimer wrong, but that lab's, it can change. Abscesses, we'll go through this one fairly quickly because again, abscesses don't just spontaneously, well they can, but usually if you have it in the skin area, you're going to have cellulitis, redness, heat, something on top to tell you. You just don't get a big old pocket of pus underneath the skin and the top of the skin looks awesome. But no, abscesses can be anywhere in the human body. They can be in the brain, the heart, the lung, anywhere. All an abscess is a generalized or localized collection of pus and debris that has essentially been walled off. There are different types of abscesses, and these are all the different types. We've already covered them. And if you think about a furnicle, because you're like, well, I thought you said that's kind of easy, not so bad. It's not, but anytime pus forms anywhere, that's considered an abscess. So if you get a furnicle that surrounds enough tissue, and there's some pus surrounding it, that's an abscess. Here are some of the places you can get them. And I put like a little bit of factoids underneath each one. You'll get these again in the specific ClinMed lectures. Again, you have some type of break in that protective barrier. A bug gets in there, Staph aureus, and causes an inflammatory response. The risk factors for the abscess formation are the same as everything else that I've already mentioned to you. Again, just be mindful of them. Clinical presentation, so this is going to be your cellulitic patient, but in the center of that heat, that induration, that pain, they're going to get a fluctuant mass that is either covered by skin, but when you touch it, you're like, yeah, you got some pus under there, or it's already burst and junk's pouring out, or it's really puffed up and you can just see a thin wall, roof on top of it, see all the pus collected underneath the skin. It had ruptured there, basically. Many different ways it can look. There are a lot of times, though, you'll get it and you won't see it. You'll just have to have the ability to do this and go, yeah, there's pus under that. So again, fluctuant means soft. You can touch it. They can range in size. Repeat slide here. If they have systemic symptoms, this would be what they are. I have had absolutely people with abscesses have systemic symptoms. So here's just kind of a step-by-step picture of a gentleman with an abscess. So here's your cellulitis. You went to go touch your finger in the middle of it. Yeah, it's fluctuant. So you're gonna drain it. So you put a blade in it, 10, 11 blade, made a little incision, and you pushed on it, and all this junk's coming out now. But do you see how no matter what you gave them, that never would have went away, never. Here's just another picture of an abscess that's hanging out there. That's a good picture. Abscesses, a lot of people are on the fence about this one. You can culture them. I actually don't do it a lot of times, but you can. But don't do this, and I'll show you this when I do my little hands-on thing with you. You can do it two ways, because if you take your swab and you do this, you just got staph all over it. What you want to do is, once you cut into them with the blade, take the swab, the Q-tip, it's just a big old Q-tip, stick it straight into the cavity, the hole, and dig like this, and take it straight out and stick it into your tube. What I'll also do sometimes, if it's a really big one, I'll just take a freaking 18-gauge needle with like a 5 ml syringe, just stick it in and just pull it back, and I'll get about that much fluid, and then send that off. It's just a big mistake. People will pop all the junk out, like that picture, and then they'll take their swab and they'll go like this off the top of the skin. I'm like, yeah, you just, no, yeah, you're gonna get staph aureus back. And again, I'll show you a little thing I'll do for you guys. Wound cultures, though, again, I don't do them a lot. I used to do them whenever I first started out, but they're a lot. It always comes back as the same thing. Staph aureus, staph aureus. These are just some of the indications of why you would want to do it. And I've already mentioned these things to you. Diagnostic workup. I put this in here. It could have been in a lot of the other slides. Anytime you have someone that's a diabetic, you always want to look at their blood sugars, because an infection will make a diabetic's blood sugars go through the roof. And they can get sick really quickly with like a DKA. So just be mindful of that. There's your septic workup. You want to do imaging. It's just a repeat here of what I've already said. But stop me if you have any questions. It's just a repeat. Treatment plan, again, if it is fluctuant, you have to drain it. You have to. If it's kind of fluctuant, kind of indurated, and you're like, crap. Because I've done it. I've thought I can get something out. I'll cut them, and there's nothing. And I'm like, you'll do it too. It's okay. If you were on that indurated fluctuant line where you're like, I don't know, you can give them time. Taylor, this is, oh, she left. You can give them the antibiotic. You can do the warm compresses. Try to bring it to a head, the warm compress. Come back and see me in 72 hours. We'll drain it then if it's not formed ahead. Those couple of slides there is just basically the bullet points of how to do an IND. I will not do these right now because I will show it to you and provide you with the sheet that is step by step. It's pretty simple. You cut them open and you push out all the junk. Your follow-up, if you've done an IND, you can do it. It's usually 24 to 48 hours if you've placed packing. And I'll show you this because you're like, what packing? If you pack it full of gauze, you need to bring them back in 24 to 48 hours to pull the gauze out. If you place packing. There are some instances you don't have to place packing. I'll show you what packing is. Here are indications for placing packing. There's also a really cool loop drainage technique you can do with somebody that you don't have to like cut them with a blade and pop it, and I can show you that also. You just take a drain, or like a tubing, and you make an incision, push out all the pus, and then loop the drain through and tie it off, and it just hangs back and forth. So there's not a big old gaping hole. And it just, so it's kind of cool. They do it a lot in the ER. There are a lot of folks I know, Rob being one of them, that they do not give people antibiotics all the time, even with an abscess, that they've IMD'd. Again, you just look at the clinical picture, because once you get the pus out, for the most part, you're good. You're gonna be, for the most part, they're gonna heal. Again, it is the whole clinical picture of that patient. But there are certain instances that you don't even have to give them an antibiotic. If they have a cellulitis with it, which most do, you need to give it to them. Because they got two things. They got the walled-off pus and they have a superficial infection going on. Abscesses are a little bit different. Augmentin is really good for abscesses. But again, I know Dr. Latassi will do your farm stuff. So just, breeze over mine. If they're systemically ill, you can put them in and do IV. Here are the good IV ones that people use a lot. Infectious disease will use. Erysipelas, the main thing you need to know about erysipelas, it is much like cellulitis, except two things differentiated. It involves the lymphatics, and it has distinct margins. Remember how cellulitis had that indistinct, fuzzy, blurry? These have a bright, red, shiny, hard plaque, and boom, like a step off into normal skin. Like it will be a raised plaque. It's very distinct. It does involve the lymphatic system though. The dermal lymphatics. Not systemic like in my armpits, in my inguinal growth. Dermal. Which is why you get more edematous look to it. Honestly, that's what you need to know for erysipelas. It's not as common. Your cellulitis is extremely common, but I wanted to cover it because it's on your list. You might see erysipelas. I've seen it one time. This one's interesting that it is caused by, this one is the group A, beta hemolytic. Group A beta hemolytic. So I would know that. I would know group A beta hemolytic. Yes, sir.
I have a question. So, I thought you said cellulitis can also cause the streaking too in the lymph nodes. So, is it just the dermis that mostly differentiates?
Yeah.
it?
So it's the dermal lymphatic. So it's really superficial lymphatics, not like lymphatics like that's throughout the body that's doing your main filtering of your lymph and the infectious processes. In your cellulitis, when you get that red streaking, is that those lymph nodes in that wherever, because you have them all over your body. Of course you have clusters that are more than others. It means it's affecting that a lot, because you have also lymphatics along your blood vessels. It's affecting that blood, it's affecting that whole area, and it's traveling. You won't get red streaking with erysipelas. If you see, think about cellulitis red streaking. It's dermal lymphatics for erysipelas. Not really the same pipeline system. I have to think about it. But that's a great question. People with really bad lower extremity edema are majorly at risk for erysipelas. So folks who have bad circulation in their lower legs. That's why I've made it red. But all of these can increase the risk. These folks are a little different in that they will have, and this is what kind of sets them aside for you when you read your case vignettes, they can have some prodromal symptoms, meaning 2 to 3 days before I came in and saw you, I kind of felt icky, had a little bit of fever, kind of tired, not really hungry. They can have prodromal symptoms. Their skin involvement, they can have the tenderness, the itching, the burning like everything else. But again, they have a swelling, shiny, well-demarcated, bright, fiery red plaque. with a very distinct border. Just know that, know that. Here's some pictures. It's very common on people's faces. The leg, I don't think that's that great of a picture. But do you see how in that face, there's like no blurriness there. It's red, normal, red, normal. Do you see that? Your Fitzgerald Atlas has excellent pictures of erysipelas in it if you want to look at it on Access Medicine, if you need other visuals. Much like your other ones, there's not a diagnostic workup for this. It's clinical picture unless they fit that picture and need it. Symptomatic treatment's important. So pain, stay hydrated. Cold compresses help these people. That's the only thing I want to point out there for you that's different than the hot compresses for like abscesses and whatnot. Cool feels better. I would never ask you a medication question for erysipelas. It's penicillins. Impetigo is your last thing here. It's very straightforward. It's a very, very common thing that happened in your little ones. When I think of impetigo, I think of pediatrics. You'll probably get this again in peds. It is a superficial skin infection seen in little kiddos. There's primary and secondary, but I would never ask you a question. I just want you to know impetigo. There's bullous, non-bullous, and ecthyma. I would not ask you a test question over that level. The difference in those are just kind of their presentation. The first one, though, the non-bullous, is your most common form. That's the one you're going to run into a lot when you see it. Two different groups of bug, or two different types of bug can be the etiology of this. The most are staph, 50 to 90%. 10% of them are the group A beta hemolytic, which is kind of cool because that's why if you look at this slide with that first bullet there, that is why if it's the beta hemolytic, if you know your bugs, they can get a post-strep glomerulonephritis after they get impetigo. So if you have a kiddo that comes in with impetigo, you follow up with them and now the mom's like, yeah, they're peeing in blood. You get a UA on them and they have blood in their urine. Don't freak out too much because it's probably a post-strep glomerulonephritis. Just remember that and put that back there. Many risk factors. For kiddos, honestly, the most of the times I've seen it is they pick. Kids are pickers. We love to pick at stuff. They pick their nose. They cause damage because they break it. The bug gets in there and just takes over. This is also something you'll see in your eczema kids if their eczema is not under control. Because with eczema, kids just itch and itch and itch and itch and itch, and they eventually break their skin down. So that's why you have to get eczema under control. This is your pathognomonic board question. You'll have a dang impetigo board question. The patient will complain of itchy, kind of burning, not so much really pain, it's usually itchy. It itches, it itches, it itches. It isn't, I've actually had impetigo when I was a teenager, which is very embarrassing because most teenagers don't get it. I picked a fever blister and I picked it and I couldn't let it go and it turned into it, and it grows fast. Like you'll go to bed with a little bitty thing and you'll wake up the next morning and it will already have spread. It grows very fast. It's itchy. You just want to sit there and do this with it. They can have some drainage. On physical exam, here's your board question, honey crusted lesions. I've told you this, if you ever see honey crusted lesions, just go down to A, B, C, and D and choose impetigo. But it's true, it's absolutely, it's like one of those medical conditions that whatever the pathognomonic is really how it presents. So it's kind of cool. They're thin, roofed, pustules, they can weep, and when they weep, that exudate, it crusts. Again, there's no diagnostic workup for that. Every kid I've ever seen, I just looked at them and said, God, yeah, we got impetigo, let's treat it. You don't have to work these folks up. Treatment plan, they're gonna need antibiotics though. I've never had a kid that came in with impetigo that I just said, yeah, make sure they stay clean and let's, you know. I give them topical mupirocin. That is my go-to. It takes a lot for me to give them an oral antibiotic. Topical mupirocin is your, think impetigo, attach it to mupirocin, you won't go wrong. In real life and on your tests. And it's usually 3 times a day, which is hard with the kid, but you gotta do it to get rid of it. Of course, if it's secondary to eczema not being controlled, get their eczema under control. That's what that last bullet point means. These are just recommendations of when you would want to initiate an oral antibiotic. Keflex is excellent for impetigo. It's excellent. Kids do very well on it. You don't have to worry about Stevens-Johnson. Doesn't cause diarrhea. Kids tolerate it very well, if they can obviously do a cephalosporin. It's excellent. I love me some mupirocin. I love me some Keflex in my impetigo kids. See that honey crust? This is a classic impetigo picture. I would memorize that picture. But it can spread. Any questions? Impetigo is pretty simple.
Not really.
It can be contagious. Yes, good. That's a great question. If you look at some of those risk factors, it's kind of sad, and I will tell you this. And it's not, you don't want to think child abuse, but the times I've seen impetigo is actually in neglect type cases. So it's close living quarters, unkept hygiene. It can be somewhat contagious. If another kid gets cut and they're playing with brother, yes, it actually is. Yeah, so you have to be really careful, and that's in that slide. Make sure you tell mom, you need to keep brother and sister away from this one. The biggest thing I tell people is don't bathe, you bathe your kids together when they're little, God. Don't do that, because it gets in the water, so be mindful of that, because you'll just spread it like wildfire to your other ones. That's a great question. It is actually contagious, so to speak. It's a good question. Anything else over this lecture? Anything? It's kind of the same stuff over and over again. Where I said know a bug, know a bug. Erysipelas is different than your other ones because of prodromal symptoms, and it has a very distinct, well-demarcated, you'll see that word, well-demarcated border. You can't go wrong with that. Even the antibiotics are repeats. If you have any questions later on about this, please let me know.